Welcome to Get the Facts, the program that provides you with information on government's policies and initiatives, information that you can use for our collective growth and national development. I'm your host, Theodore Henry. Today we're discussing breast cancer. And for this discussion, we have with us Dr. Derria Cornwall-Bernard, consultant radiologist at the University Hospital of the West Indies, UHWI Mona, and Dr. Patrick Roberts, surgical oncologist, and they will be telling us all we need to know about this health condition. Dr. Cornwall-Bernard, Dr. Roberts, welcome to Get the Facts.
Thank you for having us.
Thanks for having us.
Let's jump right into it. Dr. Patrick, I'm going to start with you, Dr. Roberts. Let's define cancer. Everybody has heard the word cancer.
Yes.
But it might be like a bit of like the boogeyman in the back of your head. Give us the medical definition.
So cancer is a group of conditions where cells in the body basically start to grow out of control. And as a result of that, they have the potential to either grow into other organs, which we call invade,
right,
or it can spread to other organs. And if it should spread to any organ that we need to be alive, for example, the lung, the liver, the heart, the brain, then that can lead to death. So
right,
this is what we would call metastasis or stage 4 cancer when it has spread to another organ.
So breast cancer, using the definition, breast cancer is when cells in the breast begin to multiply out of control and okay, so that becomes the issue. Now, Dr. Roberts, I'm still with you. Breast cancer is, I believe breast cancer feels like a female thing for many people, but that's not quite accurate, is it?
No, it's not accurate. Yes, the preponderance it's more common among females. Only about 1% of the male population, or 1% of the breast cancer population will be males.
Is there a why that it's more
we
prevalent?
think that has to do predominantly with estrogen. Obviously females will have more estrogen. But when we do see males with breast cancer, that's commonly due to a genetic abnormality, because it's very unusual for males to get breast cancer.
Okay.
It doesn't mean that every time a male has breast cancer, he has a genetic condition, but most times that's the underlying reason why a man would get breast cancer.
Unusual, but you didn't say impossible.
It's not impossible.
You didn't say impossible. Dr. Cornwall-Bernard, I need to bring you in right here. We want to talk some more about signs and risks, but especially risk. Now, how do persons know that they are at risk of breast cancer? Is it just having mammalian glands?
Well, that's a very good question. The biggest risk factors for getting breast cancer are being a woman and getting older. That's all you really need. 80% of women who get breast cancer don't have any cancer in their family,
right,
don't have any genetics for breast cancer that they know of. They test for genes, it's negative, but just being a woman and getting older. So basically, especially when you reach the age of 40, when you've reached that age of 40, even if you don't have cancer in your family, your risk for breast cancer increases. So you have to start doing your checks at around that time, like your mammogram and stuff. So basically, all women who are 40 years and over should be doing their mammogram or checking to see, because all women 40 years and over are at risk.
Doc, we have you mentioned mammogram, but we've also heard the importance of, before you even get to the doctor, the at-home testing. So what are people looking for if they are to do that sort of self-test?
Right. So that's the difference between being over 40 and being under 40.
Okay.
From teenagers coming up, women are supposed to be aware of, and girls are supposed to be aware of their chest. So every month after the menstrual period, they're supposed to examine the breast, look at the breast, check, feel while in the bathroom also after the menstrual period to make sure that there are no changes in the breast. If there are any changes at all in the breast, that no change should be ignored. The woman should go to the doctor, or the girl or the teenager or the young lady, go to the doctor to get any change in the breast checked out.
Changes like?
Changes like a lump, a nipple discharge, a rash on the nipple, the breast looking swollen or tender. And tender is a kind of funny thing, because many times that tender could just be hormonal changes, right? But if you find that your tenderness also is outside of the cycle, Because if it's cyclical, then you don't really to worry about it. But if outside of the cycle you have that funny tenderness that is not really, you can't relate to a cyclical change, then you could also check it. Although it's usually not cancer. But a rash, a nipple discharge, a lump, the nipple pointing inwards. And when I speak to rash, the rash on the nipple itself, like an eczema, can be a sign in which cancer shows up. Lump under the arm even could be a way in which cancer shows up. So we advise that women are not to, or men, and not to ignore any changes in their breast. So
sorry, let me just jump in. It's the same for men?
Yes.
These same signals?
The same signals could happen in men as well. So both men and women should be aware of themselves, and any changes, they check it out. And the men continue this for the rest of their life. Women do this up until they're about 40. When you reach 40, if you don't have cancer in your family, then you still have to now go and check the breast with a mammogram, even if the breast feels normal, to make sure that the breast is normal for truth, because the mammogram can pick up signs of cancer 2 to 3 years before you can feel any change on the breast.
Right. So let's distill this. Let me make sure I'm getting it right, or guests get it, or viewers get it right. Before 40, you need to be doing those checks. Go if something seems wrong.
Yes.
After 40, no matter what,
yes,
go and get it checked out on schedule.
Yes.
And men and women have the responsibility to check.
Yes.
Got it. Dr. Roberts, the early detection is key. Every time we hear about cancer, early detection comes into the conversation. And talk to us about the different stages of breast cancer.
So yes, early detection is key, and we ideally would love to detect breast cancer if present before someone has, there are any signs or symptoms. But the earliest stage we could detect this is what we call in situ disease. And this is when you have cancer cells confined to the ducts. And the duct is like a tube. So these cancer cells are in the lumen of the tube. So they haven't gone through the wall of the tube as yet. And when the cancer cells grow through the wall, that's when we call it invasive disease. So in situ is the earliest stage. This is not something you can detect by clinical examination. The only way to detect this is going to be on a mammogram. Then
Dr. Cornwall-Bernard, go look and see.
Yes.
Hence the importance of getting the mammogram as suggested by Dr. Cornwall. And obviously, when it grows through the wall, then, it can get bigger in size, and we can now have the cancer spreading from the breast to other organs as well, such as the lymph nodes under the arm, and it can spread to other organs such as the bone, the brain, the lung, liver, etc.
So help me out here, Dr. Roberts, if I can jump in. What you have described is what, stage 1 and...
So in situ is when it is confined to the lumen of the duct. It hasn't gone through the wall. Stage 1 is when it's going to be of a certain size, probably below 2 centimeters in size, but we don't have any lymph node involvement.
Right.
If this cancer has spread to lymph nodes, then that's when we start to get into like stage 3. And stage 4 is when it has spread to any distant organ. Now, the earlier this stage is, the easier it is to treat, the cheaper it is to treat, and the less morbidity, the less side effects associated with treatment.
Got it.
Cheaper.
Treatment, that's the word we're going to take a quick break on, and then we're going to come back. We're talking about breast cancer, and you, please, don't go anywhere.
Know your numbers and control the keys to a healthier heart. Know the numbers for your blood pressure, cholesterol level, blood glucose level, and your weight and body mass index. Find out the risks they represent and what you need to do to stay healthy. Talk to your doctor and start making healthy lifestyle choices to prevent a heart attack or stroke.
Welcome back to Get the Facts. We're talking about breast cancer with Dr. Derria Cornwall-Bernard, consultant radiologist at the UHWI, and Dr. Patrick Roberts, surgical oncologist. Now, doctors, let's jump right back in where we left off. Dr. Cornwall-Bernard, we had started talking about treatment, Dr. Roberts.
Yes.
And usually, Cancer equals chemotherapy, radiation. Now, I know we're going to talk about that. I know that's your wheelhouse. But before we even get to radiation, what treatments are generally available?
Okay, so with breast cancer, there are many different types of breast cancer.
Okay.
And so basically we have packages of treatment that it depends on the type of cancer and the stage that we caught it, that will determine the package that is delivered to the patient or recommended.
And Dr. Roberts, you gave us the stages. Yes, Dr.
Right?
Bernard.
So if you have estrogen positive cancer, HER2 positive, and there is triple negative. Now, of them, the triple negative is the most aggressive. So depending on the type. Now, so if someone has an early stage estrogen positive cancer, for example, they may go straight to doing surgery without even needing radiation or chemotherapy. And then after, they may be put on hormonal treatment for a couple of years, maybe 5 years, 10 years of hormonal treatment after, to keep the cancer at bay, or to keep the estrogen receptors that may have caused the cancer at bay.
Right.
Now, if somebody has, for example, triple negative breast cancer, right, that cancer is found to be more aggressive, especially if we catch them at a larger size. So that person may need to start with chemotherapy before they do surgery to shrink the tumor and then do surgery.
So chemotherapy is not curative by itself. It's for shrinking, and then surgery for removal. Am I?
Yeah. So chemotherapy basically is a part of helping to treat or to control the process throughout the body.
Okay.
Okay. While the surgery will deal with the local tumor.
Ah, got it.
Right? But chemotherapy goes throughout the blood now and mop up the thing all over.
Got it.
Right?
Got it.
So we don't want people to be afraid. Chemotherapy is offered at all public institutions, at University Hospital, at Kingston Public Hospital, at Cornwall Regional Hospital. We have chemotherapy offered at these centers. And we even have at Hope, you call this in Hope Institute, they offer chemotherapy. And everybody does not need chemotherapy, but if when we see your stage and the type of cancer that you have and it is recommended, it is because it is in your best interest to do so, because that is how we're going to hold the dragon and hold it down and deal with it.
Like how you said.
Right?
Like how you said.
Yeah, man. So chemotherapy is our friend.
Right.
Right? So we have chemotherapy, and some people that is all that we can offer them, like the triple negatives. And then we have now, if you know that you have a HER2 positive cancer, we may give chemotherapy depending on the size of stuff that we found it at. So we may still give chemotherapy before surgery depending, and then after that we may put them on something called Herceptin, which may give them like 17 doses of this over like a month, one dose per month or every 3 weeks or so. So that goes over some months to year, and after the surgery. And then there may be other immunotherapy like Perjeta and Phesgo. So these are all treatment medicine that is either injected or taken orally to help to treat the cancer. So we have those treatment, chemotherapy, immunotherapy, and we also have surgery, which is to do the local treatment. And it depends on the stage we caught it. The earlier we catch this cancer, some people won't even need the chemo if we catch it early.
Early detection.
Early detection is key.
I feel like asking you a timeline question, but I get the sense that you'll tell me it depends on the stage, how long treatment will take.
So how long treatment will take? You got it right. It depends on what type of cancer you have, that person has, and how early we caught it.
Okay. So we have to, now that we've touched on treatment, I want to touch on the where. Dr. Roberts, Dr. Cornwall-Bernard, you called a few names a while ago, but give our audience the map when it comes to care, when it comes to detection, when it comes to treatment. Where do people go?
So for detection, let me start with detection and then doctor can deal with others. Detection of breast cancer, we want to catch breast cancer before anybody feels anything, before the cancer tell you good morning.
Right.
So to do that, the only thing that can pick up a cancer 2 to 3 years before it say lump,
2 to 3 years.
Yes, is a mammogram.
Okay.
And you can get mammogram at University Hospital of the West Indies, Jamaica Cancer Society, Kingston Public Hospital, Cornwall Regional Hospital, and all of the private entities also as well. But these public entities do offer mammogram.
And we're not just talking about women. We're talking about men too for mammograms.
No, so men don't have to do mammogram.
Okay.
What men have to do when it comes to their breast is to be aware of your chest.
Okay.
Men and women have to be aware And if you feel any changes in your breast or chest, always go to the doctor. And the doctor for the men would order what they need to order. For some men, we may do mammogram as well, and we may do ultrasound. But what the doctor does is, I want the audience to know, go to the doctor if you feel any changes in your breast, for both men and women. And that starts from teenagers going up. When a woman has reached the age of 30, if she has cancer in her family or the breast cancer genes, that woman will have to start her mammogram at that stage
A little earlier.
Earlier. And if she doesn't have that breast cancer genes or any strong family history of breast cancer, which she could discuss with her physician, then she waits and start at 40. And at this age, when you have to start, whether it is 30 for the people with the genes or for 40, even if you've done the mammogram, even if you've done your examination and it is normal, you still have to go every year and do the mammogram, and we could add other things like ultrasound and MRI to it.
So that's detection. Now we want treatment.
Yes.
Dr. Roberts.
Yes, so as Dr. Cornwall-Bernard said, we have a public and a private system across the country.
Right.
And in every parish we have public hospitals. Our hospitals are divided into type A, B, and C. The three type A's being Cornwall Regional, Kingston Public, and University Hospital.
All right.
And then we have some type B, for example, St. Anne's Bay and Mandeville Hospital, and the others being type C. So access to the public system, any parish, someone can access the public system. They'll be seen, they'll be assessed by the doctors in that hospital. And if they need to be referred to either the type B or type C for chemotherapy, hormonal therapy, immunotherapy, that is done sometimes. And sometimes for the surgery, they may be referred to the type B and type A as well, especially if reconstruction is required, because those hospitals would have plastic or reconstructive surgery available.
Right.
But still, the bulk of the surgeries are still performed at the type C hospitals by trained general surgeons as well. But the chemotherapy is more centralized at the type B and the type A hospitals.
Got it.
As it relates to radiation, we have public and private facilities. The public facility, we have the Cornwall Regional Hospital and the St. Joseph's Hospital, Health Center, where radiation can be accessed. And that's in the public sector, so it is free.
Right.
Obviously, it's two facilities, so it can sometimes, the demand can be a lot. But they have access to the latest state-of-the-art linear accelerators to provide radiation therapy.
Got it. We're almost at our end, but we've heard about 2 centers of excellence for cancer care. What's that about?
Well, that's the St. Joseph, this radiation centers. So we have the radiation center in Kingston, at St. Joseph's Hospital, that offers radiation, and also at Cornwall.
Oh, okay.
And they're up and running.
Okay.
They're up and running. The only thing is that there's a burden of numbers. So the waiting lists may be long because there's so many people who need this and who can't afford to pay for it privately, so they have to come to the public system. But there's these 2 centers of excellence, St. Joseph's and at Cornwall Regional, and they offer radiation therapy.
Got it. Doctors, my last question. Somebody comes in, they felt something, there's something weird happening, they're stressed out. You guys offer some counseling at all? Is that a thing?
Yes, we do. We do have support system. And as a matter of fact, I think the first point of contact for counseling, as you enter the hospital, the customer service from the front desk to the doctor, is where calming comes in. Calming comes in. And I tell people, don't be afraid. Don't be afraid. Be afraid if you're not doing anything. But once you are doing your part, faith goes with works.
Right.
That's what the Lord says, faith and works. And you say, God, I am doing my part.
Yeah.
I'm going to check myself. As a matter of fact, all women who are 30 years should go to their doctor to get a risk assessment, to see if they are of the age to start, the risk to start at 30, or they wait to start at 40 with their mammogram. And you just do that every year. In that way, you know that not everybody's going to get cancer, but whoever will get it, we don't know. And if you do the checks, we will find out who have it, and we'll find it out early if you just get into the pattern of going to get checked. Going to get checked.
Right.
And that is getting your mammogram done. Go every year when you reach the age, get your mammogram done. If something is there, we'll catch it. If nothing is there, we won't see anything. And then you just continue every year to get your checks.
That's a powerful call to action, Dr. Cornwall-Bernard. And Dr. Roberts, you have the last second and a half of the program to speak to the word on your heart for our audience as well.
My advice to your audience is to be aware of your body, get checks if you're seeing any abnormalities or if you're of the age, and also be aware of your family's history. And your family history is not just the persons who are in Jamaica, but those family members who are abroad, because knowing your family history could be that key to unlock your potential risk for getting certain cancers.
Perhaps somebody has to have a conversation today, having watched this program. You know, mommy, daddy, what has happened in our family? What did happen to such and such? This has been another informative discussion centered on getting you all the facts about this topic, breast cancer. Sadly, this is where our discussion ends for today, and I'm sure you've been enlightened and made more aware of breast cancer, what it is, how it is treated, and the fact, as Dr. Cornwall-Bernard mentioned, that panic is not the right first step. You know, this has been Get the Facts, and our guests were Dr. Derria Cornwall-Bernard, consultant radiologist at the University Hospital of the West Indies, and Dr. Patrick Roberts, surgical oncologist. For more information on breast cancer, visit the Ministry of Health website. You can find that at www.mohw.gov.jm, or its partner, the Jamaica Cancer Society, their website, www.jcs.live. Until next time, I'm Theodore Henry. Thank you for watching, and take care.